This is lecture number 5 of 6 lectures on renal disorders. This lecture is on the management of the clinical conditions related to chronic kidney disease. In this lecture, I will use CKD as an abbreviation of chronic kidney disease. By the end of this lecture, you should be able to describe the pathogenesis, assessment, and management of anemia of CKD, renal dystrophy, fluid volume overload, azotemia or uremia, hyperkalemia, and metabolic acidosis. In the 3 previous lectures, we learned that polycystic kidney disease, pyelonephritis, and glomerulonephritis may lead to CKD. With respect to polycystic kidney disease, PKD progresses to CKD in half of the patients by age 60. With respect to pyelonephritis, recurrent infections or poorly treated pyelonephritis can lead to scarring, permanent damage, and chronic kidney disease. With respect to glomerulonephritis, 95% of patients with glomerulonephritis recover if the condition is treated early in the course of the illness, but if untreated or unresponsive to treatment, acute or chronic kidney disease may develop. According to the National Institutes of Health, the top 4 causes of chronic kidney diseases are diabetes, high blood pressure, glomerulonephritis, and cystic kidney disease. The nursing implication for these acute disorders having CKD as a complication or sequelae is to identify the risk factors and manage the risk factors and these precursors. For example, compliance with treatment regimen for diabetes mellitus, hypertension, and lifestyle modifications to prevent or delay the onset of kidney failure. Before we begin to discuss kidney failure or chronic kidney disease, let's examine first kidney function. What functions do our kidneys serve? The kidneys secrete erythropoietin. The kidneys activate vitamin D, and in so doing, kidneys regulate calcium and phosphorus concentrations in the blood. The kidneys produce urine, and in producing urine, the kidneys regulate fluid balance or blood volume. The kidneys excrete waste such as creatinine or urea. The kidneys regulate acid-base balance or the pH, and the kidneys also regulate electrolytes, including potassium. Loss of kidney function in CKD means that the body is unable to produce urine. Therefore, you will see fluid overload and hypertension. Without dialysis or kidney transplant, there will be accumulation of wastes, metabolic acidosis, and hyperkalemia. Because the kidneys are non-functioning or malfunctioning, the kidneys cannot activate vitamin D. Without vitamin D, there will then be hypocalcemia. Because of hypocalcemia, bones will try to release calcium into the bloodstream. This will then cause renal osteodystrophy, which predisposes the person to fractures. Because the kidneys are no longer able to secrete erythropoietin, anemia of CKD sets in. So let's talk about anemia in chronic kidney disease patients. There are two pathological processes of anemia in CKD. In other words, what causes anemia in CKD? The major cause is the decreased production of erythropoietin. A secondary cause is metabolic acidosis. A low pH, a pH below 7.35, is a hostile environment for the red blood cells. Here you see the normal healthy kidney producing normal erythropoietin. That is normal volume of erythropoietin. With normal erythropoietin production, you have normal amount of healthy red blood cells, and normal oxygenation. In chronic kidney disease or renal failure, the kidneys production of erythropoietin is diminished or close to nothing. You then have reduced production of red blood cells, and then the body begins to exhibit oxygenation problems. How do you assess for anemia in patients with CKD? Hemoglobin will be low, hematocrit will be low, and as a compensatory mechanism, there is likely to be tachycardia. Symptoms include fatigue, weakness, dizziness, headache, difficulty concentrating, and shortness of breath. So, how is anemia managed? Routine medications include iron supplementation, vitamin B12, folic acid, vitamin C to increase iron absorption. With symptomatic and severe anemia, a subcutaneous injection of erythropoietin or epogen may be required, and or PRBC, packed red blood cell transfusion. Nursing considerations: iron, B12, folic acid should be given after dialysis. With iron, you monitor for constipation, tarry tools, and iron should be taken with meals to avoid GI or gastrointestinal upset. Evaluation of therapy, you check or monitor hemoglobin, hematocrit, ferritin, and transferrin. Another way that anemia in patients with CKD is managed is through the subcutaneous injection of erythropoietin or epogen. Studies have shown that the use of erythropoietin increases the chance of cardiovascular events such as heart attack and stroke. How is that so? Erythropoietin increases the production of red blood cells, which then increases blood viscosity, which increases the risk for stroke. Therefore, there are narrow parameters as to when to administer erythropoietin. Therefore, healthcare providers should consider the use of erythropoietin or epogen only when a patient's hemoglobin level is below 10 grams per deciliters. Healthcare providers should not use erythropoietin or epogen to maintain a patient's hemoglobin level above 11.5 grams per deciliters. Patients who receive erythropoietin or epogen should have regular blood tests to monitor their hemoglobin level so the healthcare provider can adjust the erythropoietin dose when the level is too high or too low. Experts also recommend using the lowest dose of erythropoietin or epogen that will reduce the need for red blood cell transfusions. Nursing considerations, you should teach patients to report as soon as possible chest pain, high blood pressure, difficulty breathing, rapid weight gain, swelling of feet or ankles because these are serious cardiovascular complications of the drug. This slide simply summarizes anemia of chronic kidney disease with a simple visual. Decreased erythropoietin production brings about anemia of chronic kidney disease, which is managed by subcutaneous injection of erythropoietin and supplementation with iron, vitamin B12, folic acid, and vitamin C. Let's move on to renal osteodystrophy. A normal functioning kidney has the ability to activate vitamin D. In renal failure, as in chronic kidney disease, kidneys fail to activate vitamin D. No vitamin D or lack of vitamin D means low calcium, which means high phosphorus. As a compensatory mechanism, calcium is released from the bones and the patient with CKD is left with soft bones, and that is renal osteodystrophy. That's just a layman's explanation of what renal osteodystrophy is. There are three mechanisms of hypocalcemia in CKD. First, kidneys lose ability to activate vitamin D. And you know that vitamin D helps absorb calcium. Therefore, you have low calcium in CKD. The second mechanism is with kidneys failing, kidneys are now unable to excrete or secrete phosphorus. And so phosphorus accumulates in the blood. Phosphorus has inverse relationship with calcium, so calcium is now low. The third mechanism is lack of movement or physical activities seen in clients with CKD. This also contributes to low calcium. As we know, movement or physical activity builds bones. To summarize and reiterate, here you see the sequential cascade of first vitamin D, second calcium, and third PTH or parathyroid hormone. So first, kidneys are not producing activated vitamin D. And then without vitamin D, absorption of calcium in the intestines goes down. So serum calcium goes down. Phosphorus then goes up. The hypothalamus senses hypocalcemia and sends message to the parathyroid hormone gland to release PTH. PTH then tells the bone or sends message to the bone to release calcium from the bones. So there is a bone density loss, which then progresses to renal osteodystrophy, which then brings about bone pain, fractures, weakness, especially in the lower extremities, which manifests with client being afraid or unwilling to walk. All in all, loss of motor strength, especially the lower extremities. So the clinical manifestations, like I already mentioned, muscle weakness, especially in the lower extremities, which would make it difficult for the client to stand up or walk, bone fractures or bone pain. The normal calcium range is between 9 to 10.5 milligrams per deciliter. So in renal osteodystrophy, you will see hypocalcemia. A normal phosphorus is between 3 to 4.5 milligrams per deciliters. In renal osteodystrophy, you will see high phosphorus. So the obvious management for renal osteodystrophy is to give activated vitamin D. You give phosphate binders, sevelamer or Renagel is one that's common. You take it with meals because these drugs bind with food and take away the phosphate in the food and excrete or secrete the phosphorus in the stools. Stool softener, you also give stool softener because with a combination of phosphate binders and fluid restriction, the client is likely to have constipation. So why don't you just give calcium? You give vitamin D, obviously. You give phosphate binders, obviously. Why not give calcium? Well, according to this article, those who took supplements without calcium had less coronary artery calcification, which is associated with vascular stiffness and increased risk of ventricular dysrhythmias. So the long-term consequences of taking calcium supplements can be dangerous for patients with kidney disease. This is an article that shows the benefit of giving vitamin D. There is a positive association between the use of active vitamin D therapy in patients on dialysis and with CKD and improved survival. Active vitamin D therapy has also been associated with slower progression to end-stage renal disease. Now we move on to fluid volume overload. Because the kidney's ability to produce and excrete urine is impaired, fluid then accumulates in the body. As fluid builds up, it backs up into the lungs. So capillaries leak. Fluid leaks from pulmonary circulation into the alveoli. Early signs of pulmonary edema include restlessness, anxiety, rapid heart rate, shortness of breath, and crackles that begin at the lung bases. As pulmonary edema worsens, the level of the fluid in the lung rises, crackles increase, frothy, blood-tinged sputum, and diaphoresis and cyanosis will manifest. So what is the nursing consideration? The nursing consideration is to recognize this early by assessing lung sounds, respiratory rate, dyspnea, and monitoring oxygen saturation. The management includes fluid and salt restriction and removing excess fluid through dialysis. Unfortunately, fluid also backs up into the heart. So, in your assessment, you're likely to hear muffled heart sounds. You will observe tachycardia as a compensatory mechanism and also dyspnea. There are two mechanisms of cardiac complications in CKD. The first one we already talked about. There's accumulation of fluids in the body and the backup of fluids into the heart. The second mechanism is toxins accumulate as kidneys are unable to excrete toxins. The toxins then irritate the pericardium or the sac surrounding the heart, producing pericarditis. This then progresses to pericardial effusion, which is the accumulation of fluid in between the layers that cradle the heart. If liquid accumulates to such an extent that it impairs the proper and forceful contraction of the heart, this is cardiac tamponade. So we manage this fluid volume excess through fluid and salt restriction. Fluid and salt restriction depends on client status. For patients with hemodialysis, the amount of fluid allowed is calculated by this formula: 600 mLs per day plus the urine output. For example, the urine output is 400, the fluid allowance is 600 plus 400, which sums up to 1,000 milliliters per day. So the constant is the 600, and the variable is the urine output. You also need to monitor the fluid status through daily weights, INOs, capillary refill, blood pressure, and the quality of the pulse, which would be bounding in a patient with fluid volume excess. Daily weight is considered the best method in monitoring the fluid status. We now move on to azotemia and uremia. In CKD, you will have accumulation of toxins in the blood in the form of azotemia or uremia. Azotemia is a biochemical abnormality defined as elevation or buildup of nitrogenous products, creatinine in the blood, and other secondary waste products within the body. Raising the level of nitrogenous waste is attributed to the inability of the renal system to filter such as waste products adequately. It is a typical feature of both acute and chronic kidney injury. Uremia, a clinical condition associated with worsening renal function, is characterized by fluid, electrolyte, and hormone imbalances, in addition to metabolic abnormalities. The literal meaning of uremia is urine in the blood, and the condition develops most commonly in the setting of chronic and end-stage renal disease, but may also occur as a result of acute kidney injury. So, the pathophysiology or pathogenesis of the accumulation of toxic waste in chronic kidney disease is simply this. We eat protein, liver produces protein, protein is metabolized in our body. Urea is a byproduct of protein metabolism. Urea in large or greater amounts is toxic to our body and so should be excreted via urine. But with loss of kidney function, waste product such as nitrogen or urea is accumulated in the blood. So assessment of azotemia or uremia in CKD. Creatinine would be elevated, the BUN would be elevated, but platelets will be decreased. Why does thrombocytopenia occur in CKD? Because uremia destroys the platelets. So a patient with CKD has a higher risk for bleeding with thrombocytopenia. So how do you assess for uremia and azotemia in CKD? There might be encephalopathy because uremia poisons the brain. You might see uremic frost, such as the one you see in the picture in the lower right-hand corner, which produces itchy skin. Therefore, you need to do some skin care with hygiene and lotion. Too much phosphorus also causes itching. And with thrombocytopenia, you need to assess for bleeding. So the management is protein restriction, but you also need to check the albumin levels because you don't want protein malnutrition. And that person will need dialysis to get rid of toxins. Hyperkalemia in CKD. What happens? The kidneys secrete and excrete potassium. In renal failure, the kidneys are unable to excrete potassium as much as it should. Potassium then accumulates in the body, and then hyperkalemia produces peaked T waves and eventually widened QRS complexes. So with hyperkalemia, think heart. So you assess by looking at the potassium levels, of course. You may have to obtain an EKG or ECG and notify the provider. With the EKG or CKG, you expect to see tall or peaked T waves. Management will naturally include potassium restriction, which includes teaching the patient not to use salt substitutes, administration of kyaxylate. The mechanism of action of kyaxylate or sodium polystyrene is to absorb the potassium in the GI tract and excrete the potassium in the stools. The combination of glucose and insulin may also be used. The combination of glucose and insulin moves potassium into the cell. Dialysis is also one strategy to treat or manage hyperkalemia. Now we go to metabolic acidosis in CKD. The kidneys regulate acid-base balance. With kidney failure, metabolic acidosis may ensue. The pathogenesis of metabolic acidosis in CKD has several mechanisms. First, less bicarbonate is reabsorbed from the renal tubules. Second, more hydrogen ions are reabsorbed and less hydrogen ions are excreted in the urine. Hyperkalemia also contributes to acidosis. Recall that hydrogen cation and potassium cation have to balance each other. Uremia also contributes to acidosis. So assessment includes looking at the pH. The normal range is 7.35 to 7.45. So in metabolic acidosis, you will find pH below 7.35. Bicarb, normal bicarb is between 22 to 26. And so therefore you will see a bicarb below 22. In response to metabolic acidosis, the lungs will try to restore pH. How? With Cosmos respirations in an attempt to get rid of the carbon dioxide. Remember that the carbon dioxide combines with water to form carbonic acid. If we get rid of carbon side through Cosmos respirations, production of carbonic acid is diminished. Metabolic acidosis is also managed through dialysis. So we just covered the loss of kidney function in CKD in terms of urine production, fluid balance, excretion of waste, acid-base balance, regulation of electrolytes, specifically hyperkalemia, activation of vitamin D, and secretion of erythropoietin. Now we move to dialysis, which is how CKD or chronic kidney disease is primarily managed. We will emphasize the nursing considerations and patient education that goes with dialysis. Hemodialysis. What does it do? It removes excess fluid, waste products, and restore electrolyte balance. The decision to start dialysis depends on symptoms, not on the glomerular filtration rate or the GFR. Dialysis usually takes 4 hours, and there's a 3-day combination of dialysis. So a person is either MWF, Monday, Wednesday, Friday, or TTHS, or Tuesday, Thursdays, Saturdays. There are 2 types of access for hemodialysis. One is arteriovenous fistula or fistula, and 2 is arteriovenous graft. So either the fistula or the graft. How do they differ? The initial use of a fistula will take 2 to 4 months or even longer. The initial use for a graft will only take 1 to 2 weeks. Why longer for the fistula? Time is needed for the fistula to mature. Increased pressure of arterial blood flow into the veins causes the walls of the veins to mature, that is, to thicken and become strong. Excuse me. Nursing considerations for the AV graft or fistula, you need to check for bruit or a swishing sound and thrill or vibration. These are normal findings. Bruit and thrill are normal findings in both the fistula and the graft. And then on the arm with the AV fistula or AV graft, there should be no venipuncture. Uh, so don't compress the arm. No blood pressure is taken on the arm. No tight clothing. Don't lie on that arm. Don't lift heavy objects with that arm. But you need to encourage range of motion. What are the nursing considerations before hemodialysis? So you need to coordinate with a provider regarding the drug regimen on dialysis days. Notable are antihypertensives, vasodilators, anticonvulsants, vitamins. These drugs may have to be withheld, typically not given before dialysis, because dialysis will simply be dialysis will simply extract these drugs from the circulation. You need to check with your facilities protocol. After dialysis, you need to monitor for bleeding because heparin is infused to prevent blood clots from forming within the dialysis machine. Heparin remains active in the body 4 to 6 hours after dialysis. So you need to monitor for bleeding. The antidote for heparin is protamine sulfate. Remember too that a person or patient with CKD is likely to have thrombocytopenia. After dialysis, you need to monitor for hypotension because a lot of fluid was removed during dialysis. And after dialysis, you need to monitor for dialysis disequilibrium syndrome, which is increased cranial pressure. Dialysis disequilibrium syndrome is increased cranial pressure. So you need to assess for decreased level of consciousness, headache, nausea, and or vomiting, restlessness during and after hemodialysis, because early recognition and treatment with anticonvulsants and barbiturates may prevent life-threatening situations such as seizures and coma. Peritoneal dialysis. Please click on the video, on this hyperlink to view the video. The advantage of peritoneal dialysis is that it can be done at home. It's easy to learn, no machine is needed, and there are less dietary restrictions, and there's better blood pressure control. The disadvantages are it's time consuming, sterile technique is required, and there's a risk for peritonitis. So caring for patient with a peritoneal dialysis catheter. Peritonitis is the major disadvantage and risk factor in peritoneal dialysis. The cause is usually the connection site contamination. So the prevention is meticulous sterile technique. How do you assess for peritonitis? Um, you will see cloudy dialysate outflow, which is termed effluent. Um, you will see abdominal pain and tenderness, nausea, and or vomiting and fever. Just remember that the cloudy or opaque effluent is the earliest sign of peritonitis. So if you see that it's opaque, you need to send a specimen of the effluent for culture and sensitivity. Or you need to educate your client that if he or she observes that the effluent is opaque, she needs to send a specimen of the effluent for culture and sensitivity. And the treatment is, of course, antibiotics in the dialysate. This ends lecture number 5 of 6 lectures on renal disorders. Um, please read your textbook, and then we'll move on to the last lecture, which is acute kidney injury, which is lecture number 6. Thank you.